warahmatullahi wabarakatuh. Thank you so much for wonderful. Dr. Fauzi, welcome to Pakistan. I know it's for a short while, but you're always welcome. It's a pleasure to, and to all the panelists. Assalamu alaikum warahmatullahi wabarakatuh. इतनी तारीफ तो वैसे घर में भी कभी नहीं, ना ससुराल में हुई है तो, but anyway, thank you so much. Before I kick off, obviously I'd like to thank the organizing committee for inviting me. And there was the invitation card which says DOCTORSCON. तो मेरा मरीज कहता है DOCTORSCON, मैं कहा हाँ स्कून वाले डॉक्टर ने सारे स्कून. They all give you the schoon. So anyway, thank you so much. So I just discussed with somebody. He said, what's your topic? I said sulphonylurea. He said, sulphonylurea? 2024, you are coming about this. So I'm going to give you a different twist, particularly living in Pakistan, and the type of the patients we see. So I think will give you a bit of a reason to actually support this idea, but I don't know how many of you will actually agree with that. So starting with the name of Allah Ta'ala, welcome to the diabetes seminar, and coming up for the next 20 minutes. I think for the topic it is very short, but I'll try to limit it to the timing. And in the next 20 minutes, this is a glance at the past and placing sulphonylureas in the type 2 diabetes. And the next question is, all the sulphonylureas are the same. So I think this is terribly important. If you were really focusing on the last speaker, he actually did mention about one of the molecule which I was actually going to discuss. So a glance at the past, and I think it is still present and maybe in the future as well. But before I actually get on to the particular topic about it, but I like to really pick up a bit of a contention and bone among all of us, because where we are heading. So by saying so, this is a war on diabetes, not just Pakistan, but globally. And this is the state of affair that it's killed about 6.7 million people worldwide in this IDF 2021. I don't think so there is the latest data of the IDF released so far, but this is something which is really a wake-up call, and really the journey people they go through once they actually get diabetes, and as the time passes by, it is terrible. वैसे तो कुरान में है कि there is a time to die and time to be born. So one death after every 5 seconds, but the important fact is, I'm just going to take you back that this is a mostly poor socioeconomic countries, and most unfortunately so far, Pakistan actually falls into this category. So one death after every 5 seconds, and Pakistan and diabetes. Dr. Sahab, mind na kijega, but this is the reality which I really would like to discuss now briefly, and maybe towards the end that where we are heading. Highlighting the bitter truth, and it is an unfortunate and undeniable reality. It's a real shameful concern, because I think the next slide will show us where we are heading. This is what it is. There's something terribly wrong with the standard of the healthcare approaches, because the fact is, the result itself tells you, अगर बच्चा सारा साल खेलता रहे और आके फेल हो जाए, तुम आगे तुमने किया पढ़ा तो थे नहीं तो फिर. But this slide basically tells us where are we heading, and I'm just going to take just a minute or two to bring it to the update, and I think the topic would remain open for centuries, what to do, which way to go, because what is happening here is 2011 the prevalence was 7.9%, and you move on to 2021, this is the IDF at list number 10, and it has gone up to 30.8. Why? We have so many meetings coming up. We have midsummer, midwinter, so many meetings then. I think there is something wrong. We need to really be focusing some other direction, so that this, Pakistan was number 9 on 2011, and is now number 1, 2023. So really, this is Surah Baqarah, I think ayat number 152, and that's exactly the fact. Why it is so happening, in my personal opinion, it is the disunity among the doctors community, because the people taking actual chances and spending the funds in a totally different direction. And I think it is extremely important that we all should actually get united under one roof and put our all the forces and the facts on towards actually bringing the awareness towards the patients. Diabetes, poverty, and desperation. That's absolute. We cannot deny that. The fact is, it's 3 in 4 people with diabetes live in the low and the middle social income countries. And now every time we go, I'm actually based between London and here, and every time we meet these meetings, there is a drugs, molecules coming in so expensive, but knowingly that we actually come from these parts of the world which is so economic country, where is the affordability? Where is the money? How can we actually do that? So really we have to do something different from the rest of the world when we are living in this country. And I think this is pivotal point and extremely important to focus on this one. So diabetes, you know your enemy. This is the beginning of the things. It's the glucose. The higher the A1C, the more risk you have a microvascular. I think it's a fact. I'll just rush through the things which I know for granted that we all know that. But this is what it is. This is primarily is the glucose. So when we talk about diabetes, in the first place we talk about glucose above the normal limits. And this one slide, this is the puzzle which basically gives you in just one slide, it basically gives you the summary of what actually is going on. But out of these two sides, from the micro and the macrovascular, if you really focus on just one point, that will be the winning things. And this is the glucose for both macro and microvascular. Why I'm saying so is, and not touching on the other side, I'll just hold on and I'll just take you along. So early glycemic control is cost effective before complications set in. And most unfortunately, I think all of you would agree with me that by the time patient actually gets into the hands of the professional people, we actually are sailing into the stage that there is hardly any U-turning. So before the complication sets in, I think it is extremely important that we screen people and get them going with after the lifestyle management with the minimum possible least expensive drugs which are going to take care of our patients. So the time is precious. This is the message which I would like to give it to our patients and to the community as well. Hyperglycemia per time is complicated. It's a unique equation which tells you, yes, Mundar, this is just not just 3 words, but this is the ocean which basically tells you the story of the diabetes. So we always had a learning brain, and early versus late control of all the risk factors. I think the bottom line is the word early. Now, Dr. Fauziya, there has always been a thing to say that all the diabetic patients are cardiovascular risk equivalent. This is a conventional wisdom, and I would like to ask, if you're not going to re-answer that, would you say it is true or false? Because then diabetic patients, they are all cardiovascular risk factors. Is it true or false? It's true. Well, generally speaking, the patients with the diabetes are at a high risk of the cardiovascular. But if they are left alone for too long time period, they will become the cardiovascular risk factor. But if somebody who is, say, late 30s, early 40s, has just got one risk factor, is the glucose, I don't think so when he has got no hypertension, no dyslipidemia, no smoking, that he is going to be cardiovascular. So depending upon individual, I think it is false. It is generally true, people are more likely to get this, it's 11 minutes. So people are likely to get more risk for the cardiovascular disease at any stage, but when they are right in the beginning, and that is where we should be clamping it down. Treating diabetes type 2 with sulphonylureas, a difficult topic to support, but I'll try to actually give it a spin, and then I love to actually generate the sort of a discussion, a healthy discussion, to see which are the things moving. Where are we in 2024? Are all the sulphonylureas just the same? Or within the class there is a difference? I think there is a well-known story of rosiglitazone with pioglitazone. Rosiglitazone was stopped and the pioglitazone is still going on. Benefits of the early glucose-centric potential. So if you can see here, I'm not really discussing about the hypertension or anything. I'm just focusing on the glucose. So right in the beginning, if you can just control after the lifestyle management, just the glucose, I think you could perhaps be avoiding many, many complications, both micro and macrovascular. So the question, if you could design the perfect medication for the diabetes, what should be the properties should be? Ideal drug. It should have HbA1c reductions. I think this is self-explanatory. You can see those ones. So multiple factors, and the most important thing out of this is the cost. It has to be bearing in mind that we come from the low economic social circumstances. I think it has to be a cheaper drugs. Available hypoglycemic, these are the approaches we have, and just recently we just got the once weekly DPP-4 as well. So personally I think if you have a person who is from a low socioeconomic condition status and at an early stage, I think this could actually fit in, because we are not talking about the cardio or the renal protection at this point in time. And the other thing is the insulin. The reason I have actually inserted the insulin with sulphonylureas is, please be careful when you're using insulin and sulphonylurea because of the two factors. One is the hypoglycemia and the other is the weight gain. So the next question comes up, are all sulphonylureas the same? And I personally think this is the pivotal point to say that no, they are not. And the reason behind is, the inside story is the beyond the wing. The first sulphonylureas which came out in the world was tolbutamide. And they actually did the study called the UGDP, the University Group for Diabetes Protection, and then it went on to the latest second generation glycoside, MR or CR. And this was started in 1972. Message from the multiple trials starting from 1960 to December 2008. The tolbutamide was stopped. This is important. That is why people say, no, sulphonylurea, it's obviously you could be having ischemic heart disease, cardiovascular problems. The tolbutamide was stopped due to the increase in cardiovascular mortality, and this warning was missed by the hypoglycemic approaches can increase the risk of the cardiovascular. Absolutely true. And that basically raised an unexpected adverse effects, created a storm of controversy. The controversy was, if you have a control of a good glycemic control, you could be decreasing the microvascular complication, but the macrovascular complication remained a question. But those are the patients who were left unattended, hyperglycemia for a long time. So hyperglycemia plus time is complications. This is the way the sulphonylureas work. Quickly speaking, obviously once you have a high glucose level, the ATP increases, the KTP channels are actually blocked, there is a depolarization, calcium channels actually are in flux, and then the exocytosis bringing in the insulin. This is generally what it happens. Now, sporting the latest sulphonylureas, the glycoside CR, there is something called as the ischemic preconditioning. I don't know how many of you know that. The ischemic preconditioning is that when you keep having a repeated angina or ischemic attacks, there is an adaptability within the system. That is why in Quran it says, لَقَدْ خَلَقْنَا الْإِنسَانَ فِي أَحْسَنِ تَقْوِيمٍ, that we have actually produced in the best mode. So Allah Ta'ala primarily within the system has given adaptability. And once that adaptability is blocked by the previous sulphonylureas like tolbutamide or glibenclamide, then you have a chances of getting a massive heart attack. So the question of ischemic heart disease and the ischemic conditioning, then the glycoside CR or MR basically supported that it actually blocks that response. The sulphonylurea glycoside CR does not actually block this response, but the others they do. So you are at a risk if you are using the first generation sulphonylurea. So important difference between the glycoside CR and early sulphonylurea is the ischemic conditioning. Then the next question was that if you bring the HbA1c closer to the normal, would it be a winning combination? They brought the three well-marked launch trials, which was the advanced trial, VADT, and Accord trial. And what the message was, the advanced basically used the glyceride CR only, and this is what it stands for, the advanced trial. Why glyceride CR was used? This is important. The glyceride CR was actually chosen for advanced trial based on this fact. So the CR acts selectively on the adenosine potassium ATP channels at the pancreatic beta cells only. It does not actually block the cardiac ATP channels. So that is why they actually had chosen, and you can read it yourself. It's obviously, I'm not going to be reading all that, but that is indicating that the drug can be safely used in patients with ischemic heart. So the concept we have at this point in time is that if you're using sulfonylurea, you will actually going to have a worsening of your ischemic heart disease, but that doesn't seem true when the advanced trial was actually going on. So what does the evidence tell us? The evidence basically tells us that in advanced trial, if you were using it, there was a drop from 7.3 to 6.7, 91% glyceride MR regime was used. Because of the limitation of the time, I can't really go into the details of those. And this also had a cumulative incidence of events both on the microvascular and the macrovascular system. So what we are talking about here is the cardiorenal protection with the sulfonylureas. And it is supported by the well-acknowledged trials. So the glyceride CR-based therapy is significant reduction in renal events, micro and macrovascular, new or worsening of the nephropathy. And this is what was shown, that there was about 21% decrease in the new or worsening neuropathy and 30% in the microalbuminuria. The weight gain always remains a problem. Any of the drug which gives you a weight gain and a hypoglycemia is not acceptable. So this is basically supporting the fact that if you're using the second generation sulfonylureas, there is zero weight gain based on the advanced trial. All sulfonylureas are not the same. That's again the same what I've already said, that the glyceride MR or CR primarily does not have potassium ATP channel in the heart, so it does not actually affect the cardiac effects. And this is again showing the same thing, that not all the sulfonylureas are the same. And this is the trial basically, which is showing the difference between glimepiride and the glyceride CR. I think there is a bone to pick up. The question remains, is there a really difference between glimepiride and glyceride CR? But I'm not going to go into the details because of the limitation of the time. So sulfonylureas in diabetes, this is again, this was a paper posted in March 2012, and this surely shows that the incidence of hypoglycemia was much lower in glyceride than the other sulfonylurea. So I think there's a lot of support in the favor of the latest. There's nothing after that, but the glyceride CR has been the latest one. So there must be a difference of opinion what I have actually gone through, and during the question answer time period, I think we can actually discuss that point, because this is what is the first line treatment after lifestyle management in a country which is basically poorly socioeconomically driven, and I think we all actually have to join hands to find out what is the best solution. So joining hands for the early diagnosis and early intensification in diabetics is extremely important. There's 1 minute and 45 seconds left. So let's act today to save tomorrow. I think this is my message, that we all should actually be focusing in a different direction. I think the awareness remains the problem in the public and among the doctors. So if you're not joining the hand, then you pay the price. And I love this one, because if you're not going to go through this, this is an unexpected, you can say the complete, dead in bed. You know, a lot of diabetic patients you will find, they were actually found dead in the bed. So if you are not really rolling up your sleeves and putting your nose into it, the role of the SGLT2 and GLP-1 will come into play. This is only when you have developed complications. So the message here is very clear. You want to avoid all this, You have to act early. You have to screen early. मैंने थोड़े से गुलाब जामुन खा लिए थे, ज़्यादा हो गई योगा. So if you're going above 5.7, I will say that's the time you should roll up your sleeves. So dance before the music is over and live before your life is over. This is again Quran, Surah Al-Munafiqun. Go back and read the last thing. وَأَنْفَقُوا مِمَّا رَزَقْنَاكُمْ مِنْ قَبْلِ أَنْ يَأْتِيَ أَحَدَكُمُ الْمَوْتُ. लोगों खर्च कर लो इससे पहले कि तुम्हें मौत आ जाए, और फिर तुम कहोगे फस्तदकुम मिन स्वालिहीन कि अल्लाह ताला हमें दोबारा भेज दे दुनिया में तो हम सदका खैरात करें, तो हम स्वालिहीन में से शामिल हो जाएं. With this token, I would like to thank you all and say it's the time which is important. Thank you so much to you. Thank you. You know something, this is, if you go back and read this Surah Al-Munafiqun, it doesn't actually give you just towards your health and all that. It basically tells you this is the time. We're not going to come back into this life. And the same remains with the diabetes. If you let go through this and you basically do not really look into it and let it flow through, you develop a microvascular and macrovascular, फिर ये तौबा कबूल नहीं करती. या अय्युहल्लज़ीना आमनू तूबू इलल्लाहि व तौबतन नसूह. नहीं, that is Allah's शान करीमी, but diabetes is different. So please mark it and underline it early and good control right in the beginning. Thank you so much. Thank you.